Good morning. I am Barbara McCann, and I am very happy to say that I am a provider. I have done home visits in hospice and home care, and now have the privilege of working with new delivery systems throughout the nation. And following the last speaker, I want to also tell you that I'm a medical social worker, and we do have intervention for the onset of clinical depression as we go forward. I want to begin with probably 5 trends, if I can, of what we see as the reality of what's going on every single day in this nation. Right now, at this very moment, thousands of people over 65 who are Medicare beneficiaries are receiving home health care, and many thousands others under Social Security disability are receiving health care. The problem is the following, because I think before we take off for the future, we have to know what's working and not working now, but I'm going to say it hopefully in a little bit different terms than studies. This benefit was created years ago, decades ago, and it emphasizes recovery, acute illness, the opportunity for improvement, and that those problems end. The reality in this generation and the generations following us and those in our parents and grandparents who are still alive is that it is an acute benefit caught in the robes of chronic conditions that now go on for decades, for years. And it does not emphasize wellness or prevention. And very unfortunately, it does not provide payment for comfort or palliation at the end of life, because many people do not die in just 6 months. It's a long, ongoing process. The other challenge is that most people never even know that home care exists until the moment of crisis, when they walk into your room and say, your mom's going home tomorrow. We hope that works out for you. And you get the list that Mr. Martinez got, and maybe you don't know who to go with at that particular point. And that happens not only from the hospital, it happens from the inpatient rehab, and it happens from the nursing home. That crisis, I'm telling you, you cannot be prepared for it the moment it happens and they go, a nurse will come tomorrow. Whether or not it's a nurse, but a nurse is coming to your house tomorrow. So we have to end benefits right now within long, ongoing chronic conditions. And when we finish our care, because the regulatory definitions of the benefit right now say they're no longer homebound, they're able to get out, so care is over. Guess what? Chronic disease goes on, medications continue to come into the house, and we have to say goodbye. And quite honestly, although I am personally able to live within the happiness of a patient-centered medical home, that isn't across the entire nation. I have no one as a provider to hand off the next transition to say what happens. Now let's go to happiness. This is the innovations that we're seeing. What I love about Americans more than anything else is if that's the way it is, then we're going to find a way around it. And so within ACOs and progressive practices throughout this nation, we try to break what is right here I'm presenting is the chronic care mold that happens. So we have now physicians that will call home care from the emergency room or from the urgent care centers they now own and say, let's not talk the home health benefit. Could you give me 6 hours of nursing care in the next 3 hours and get her home? And maybe I need aides the next day, and maybe we'll go to home health, but I think we can get her stable and she'll be fine. And we go, yes. And yes, we do get them to pay the bill. Now we move on over time, and we have doctors that call us and say, I'm not really sure that she can really do this well. Could you make 2 visits, one over the next 2 days each, and see how she's going? I don't want to know about OASIS questions. Here are the questions that I need answered to see if she can manage on her own. Or could you have the PT or OT go out for a day? I'll pay for the visit. They're kind of weak and wobbly, and I don't need her falling between the toilet and the wall again, because this time she'll break her hip. And so we find ways around it that don't require visits every day, but help those people to stay home healthy. And then the end of life. Very often, we are incredibly successful with putting aides in the home, homemakers, help clean, dress, get meals going, and being able to reach out to the doctor that has a background in palliation and the nurse, and they may not have to come to the home all the time, but can help the family manage comfort and symptom management, and they stay in the home. A less intense, more friendly, but equally effective way to deliver home care that within the challenge of being able to do it cheaper, we see people making those advances every day and stepping outside of the model. Dr. Coleman and Mary Naveler helped us teach and learn about transitions more than anything else, which was wonderful. We began to think differently about leaving the hospital and what that means. You know what? There's transitions every day, all over the entire system. And when you are sitting there as a home health provider, you step into what is the reality of home care. And let me talk to you just briefly about what that is every day if you've never experienced it or you haven't been with your parents or grandparents yet. It is not just post-facility. It is post-doctor office visit. They can't remember what they talked about, who they told about, what symptom, and they certainly cannot remember what the doctor told them to do at that point. They can't remember what medications to take. And even as an informed provider, you get home with your own parents the first day, and I want to introduce a concept. The reality of health in the home is the reality at the kitchen table, because that's where health decisions are made and that's where health is managed. And you sit down and you got the bag from the hospital and what they told you to fill, and you got the other ones, and you don't know. So you know what most people do? They either take all of them or they take none of them. And we have a problem, and we see readmissions on an ongoing basis. They can't tell what symptoms are the things they should watch for and where they could reach out earlier and get intervention. All symptoms are the very worst at 2 o'clock on Saturday morning. Whether or not they're important, critical or not, that's when they feel the worst there. And then they can't remember which doctor to see and when. And at this point in time, home health may say you're stable enough, you're at a maintenance level, we need to leave. And here's what happens. This is it. This is what goes on in the home and what every child, grandchild, spouse faces. Mr. Martinez did such a beautiful job of presenting this morning. If we did this better, if we thought and rethought home health better, could this make a difference in cost, the availability of caregivers, et cetera? Right now, it's pretty much a burdened family. Let me just say, an incredibly stressed out middle-aged woman most often, and private pay as much as they can get through to deal with these things. Remember to take your medicine. Are there better ways to do that? Are there machines? Is there something that will remind them better? What are the chronic diseases and the symptoms for them to watch? Mom, your legs are swelling more every day. Get your feet up, right? There's nobody there to say that all the time. Call the family, let them know the symptoms are worse, get to the doctors. Getting transportation, you may make the appointment, they can't get there. Meal prep, when you don't feel well, you don't go out and fix dinner, and you don't fix lunch, and you don't fix breakfast. Is there a better way to deal with that in the process? Supporting safe ADLs. For those of you that are not in the healthcare industry, the basic pieces are, folks, you got to be able to get up, right? Get off the chair, get in the chair, get to the toilet, get dressed, and take care of yourself and bathe. That's it. Those are the AD, activities of daily living. That's what keeps us at home and out of a nursing home most often, whether or not we can do it. And then as a social worker, I need to say we probably need to face socialization, and it means more than The Price is Right, The Ellen Show, and Dr. Oz in the end, and how we keep people engaged daily. The next trend that is a wonderful challenge is machine or person. Right now, if you gave me a robot nurse for my dad, I'd be very, very happy, and I think he would also. But let's think about it differently. Who needs to be in the home, when, and for how long? Now, by virtue of the innovation that's been going on, we've done something wonderful. We have an entire group of people concentrating on those the first 30 days outside the hospital, right? We have the PCP, who now is going to get engaged from a community standpoint. Here's our challenge. We have the navigator from the hospital who shows up when the home care nurse also shows up, and they think it's everybody's either home care or the navigator, and now we have a new problem. Out in the West, we have the EMTs. I guess we've cut the ED rate so low, the emergency department, they have nothing else to do. And so we actually have arguments between home care nurses and EMTs who have showed up to help with medication reconciliation at that point. But once you get past 30, 60, 90 days, folks, chronic illness, aging, disability continues for weeks, months, and years. What's the right type of intervention by person, by technology, and for how long after those 90 days occur, and for the variety of people? I'm very sad to say that we got lots of data and we got almost no information in home care. In the Medicare world, step back and think about what we have. In the year 2000, we started, whenever they received skilled care, nursing, therapy care at home, we collected over 100 data elements on every individual in Medicare fee-for-service, regular Medicare, listen carefully, Medicare Advantage, Medicaid skilled care, and Medicaid managed care. We have millions of episodes sitting in a database somewhere that have not been analyzed. We get information back about what makes a change, how good we're doing, but what we don't know is if that's equivalent for Medicare Advantage, Medicaid Advantage, intermittent maintenance visits from nurses, or old-time Medicare. In other words, we don't have the ability to sort that data out and say what works and what doesn't work. So if we're going to talk expenditure, wouldn't it be nice to know what combination of timing, discipline, et cetera, actually results in positive outcomes? We don't have that at our fingertips right now. But even if we did, we have another whole section that's missing. Briefly, private pay, personal care and support services. What if we knew that an aide every day, as they do in Australia and Great Britain, who have a different approach to aging at home and the payment for health care at home, if they came and got dad up, dressed, fed, et cetera, and maybe came back at night, is that the winning combination and you don't need as many nursing services or therapy services? I don't know, but we could know in the process. I have the privilege of working on bundling with some physicians. And here's our problem. I'm very sorry to tell you, but we can't actually talk to each other. Because how the physician assesses pain is not necessarily how the physical therapy in the hospital does or the home health agency, et cetera. Quickly. It makes all the difference in the world if we had just a couple of things that were the same across all settings and simple enough that if we shared it then with the patient and the family, it'd be the same thing. How's your pain? 1 to 10. What's frailty? What can we say? You know, he's not doing well. Tell me about that. I think there's some problems here. Function. Could we all talk about the ability to go to bathroom, get bathed, et cetera, the same way? And the very important thing we often forget, is there an able and willing caregiver in the home? 2 critical elements in the process. With that kind of common language, we have a big opportunity to go forward. Legislation has just passed that will help promote that, but I'd like to see it not just post-acute, I'd like to see it all the way back to the doctor's office, that we all speak the language in going forward. Surprisingly, one of the most wonderful experiences I have had are duals demonstrations in the States as they are emerging now. I'm not going to kid you, it is not easy, it is incredibly hard, but we are speaking a different language. For those who are long-term disabled and for the elderly that meet both Medicare and Medicaid qualifications, we're actually talking about coordinating care across the continuum. A person doing that, or persons. Most often, 2 nurses and a social worker in a pod. Isn't that interesting on the discipline? We aren't talking just managing illness now. We're talking about wellness, prevention, and a new word I had never heard of, but it's becoming my favorite word, habilitation. I may not be able to rehab you, but I can help you live better in your home. Move the pots down and the food up so you can lean over. Take care of the toilet so you don't fall off. Can I live in my habitat longer with some help? Longer and longer, but not costing as much in the process. As a social worker, I'm so thrilled that in the duals demonstrations, we talk about health as being psychosocial, family, economic, neighborhood, meals. And so we're seeing meals delivered to people in their homes, not just on Meals on Wheels, but according to their diet overall. And the argument over maintenance versus skilled intervention stops. It's when do they need the skills of a nurse, a therapist to be in the home, not within episodes. I guess I'll offer the promise of home care from what we're seeing now, the trends in the nation, for your consideration as following. Healthcare in the home is not an episode. It is over time. Sometimes that time is short. The wound post-surgery heals, the infection is gone. For others, it is weeks, months, and years. We need to know when you need eyes and people in the home and who's going to make that decision. It may not be every day and still have quality outcomes. Transitions are more than post-acute. This is an incredibly difficult system to navigate. And so how we coordinate it, especially when people are overwhelmed with illness and just an acute exacerbation, is important. Could we do something better about coordinating that? We don't have to be in the home to do it, but that's where the decisions are made. Home care doesn't always mean a person in the home. My 30-year-old son will use the app. I will do email. My mother, under no circumstances, will do anything at 86 other than talking to a live person. So we found a solution. It's a PERS unit, but with an active call center. So at 2 o'clock in the morning, when she can't remember which pill to take, the call center hooks her up with a pharmacy where they come to the decision. That's all she needed. But she's not going to email anybody or check an app to do it. So cognitive and age appropriate. And we need information quickly. When home health is there at our best and in front of individuals and their families, please realize we have more face time than any other provider in the entire system, in the kitchen where they make the decisions. I don't think we can manage populations without it. I would be remiss without Mrs. Russo. This is the present of home health, but it's also the present in terms of a gift. She got her hair done for you. She has a lovely shift on. She put her shoes on, but her feet are a little swollen. And you can be sure there's a very scruffy foo-foo over on the other side being restrained. But this is what we have to remember about the beauty of home care. It's at home. Thank you.